Thank you. I'm honored to be the final speaker of such an amazing symposium. My name is Dayna Skolkin. I'm a nurse practitioner at the Center for Advanced Heart Failure, and today I'm going to be talking about non-device, non-pharmacological interventions in the critically ill patient. So you all are probably familiar with this picture of a typical ICU room with all of the devices and the medication trees. As you know, all of these devices and medications do have consequences. So today I'm going to focus on the interventions that are needed to get patients back to their prior level of functioning. Patients have long-term medical, physical, and cognitive disabilities that last years after their ICU stay in a phenomenon known as post-intensive care syndrome, or what I will call PICS for the purpose of this lecture. Research has suggested the ABCDEF algorithm for management and prevention of PICS, and I will go through each of these during my slides. Firstly, after a patient is stabilized, focus should be on sedation vacations and spontaneous breathing trials. This has been shown to decrease mechanical ventilation by an average of 2 days and ICU length of stay by an average of 3.5 days. Just as the organs suffer damage from the inflammatory response of shock, so does the diaphragm. So in response to the inflammatory response, the mitochondria produces toxins, which activate the ubiquitin proteasome pathway, leading to proteolysis and muscle atrophy, which weakens the diaphragm. Luckily, these interventions have been shown to be effective in strengthening the diaphragm and decreasing this pathway, as well as inspiratory muscle training, in which patients are taken off the ventilator and allowed to breathe a few breaths on their own to strengthen the diaphragm. If unable to get off the ventilator, data does support the use of early tracheostomy in patients, which is defined as either less than or equal to 7 days or 10 days based on study. But you can see in this slide, this is taken from a Cochrane database of over 2,000 patients, that there are positive outcomes in association with early tracheostomy. And in general, patients are more comfortable when they are awake on the ventilator than on an endotracheal tube, and the use of passy-muir valve allows them to communicate and to eat more quickly. So now we are at the C of the PICS pathway, which stands for coordination of care and communication. I'm going to give a few examples of the multidisciplinary approach that has been shown to be effective in personalizing care for our patients. Firstly, you see a patient who was put on nectar-thick precautions due to aspiration, and her favorite food was popsicles. So in order to get her nutrition and to get her favorite snack, our APPs and dietitians made special popsicles for her. I don't know why this video isn't playing. Secondly, this is a patient in cardiogenic shock on Impella support, and his main goal was to be able to play catch with his grandchildren. So our physical therapists and staff members practiced by throwing the beach ball in the halls with him. On to the D of the PICS pathway, which stands for delirium assessment and prevention. And delirium is the single most important long-term predictor of outcomes in patients after their ICU stay, and it occurs in 50 to 80% of mechanically ventilated patients. Non-pharmacological interventions, such as ensuring normal sleep-wake cycles, environmental modifications, and early mobilization, have been shown to be superior to pharmacological agents, especially to the use of benzodiazepines, in preventing and managing delirium. So the E standing for early mobility. Our patients get deconditioned very quickly, and the reason behind that is, again, with the inflammatory response, there is damage to both muscle and nerve cells in a phenomenon known as ICU-acquired weakness. This can be divided into myopathy and polyneuropathy. Myopathy is caused by proteolysis and is caused by an actual loss of fast and slow myosin chains. And it's diagnosed based on muscle biopsy, and here you can see that the patients with myopathy have a smaller muscle fibers compared with a healthy patient. As opposed to myopathy, polyneuropathy is caused by damage to motor and sensory nerves, and it is diagnosed based on EMG studies. These patients have decreased response to pain, temperature, and vibratory sense, and compared with a healthy patient, the EMG studies of this patient has decreased amplitude and velocity. So why is this so important? Well, it occurs in 40 to 60% of mechanically ventilated patients and happens in as little as 4 to 7 days of ICU stay, explaining why our patients become debilitated in the ICU so quickly. Their healthcare providers may be concerned with mobilizing patients with femoral lines or ECMO, although data does suggest that there's very low risk associated with mobilizing with these lines. So finally, the F of the PICS pathway stands for follow-up referrals and functional reconciliation. How do we track our patients across the continuum and in the inpatient and outpatient worlds? The AMPAC, or Activity Measures of Post-Acute Care, is a tool that's used by physical therapy and occupational therapy that measures these 3 domains and gives a quantitative score that can be used to track patients' progress inpatient and also once they go to outpatient rehab if they should need it. So putting this all together, I'll give a story of a patient that was treated at our center that these interventions were used on and were shown to be a great success. This is a 58-year-old, presumably active gentleman who came to our center with a STEMI. He underwent PCI to LAD that, in course, was complicated by in-stent rethrombosis and cardiogenic shock requiring tandem support as well as ECMO. He spent months in our hospital and became severely deconditioned. He lost 60 pounds and was wheelchair bound, but he was determined to be able to walk again for himself and for his children. And I will show a video of him now. Despite his EF of less than 20%, here he is with NYHA class 1 symptoms. So just to wrap up, just as there's no biomarker for cardiogenic shock, there's no biomarker for where a patient wants to be with their functional status. We need to personalize our care based on where people were before their hospitalization and what their goals are and where they want to be. So thank you.
Dayna, I think that was a beautiful wrap-up of the whole concept of what we've been discussing, that just doing devices and treating shock and drugs are just a small tip of the iceberg, but for the patient to go from hospital back to home are the interventions that you're talking about. I think you've definitely shown us that in the next shock symposium, we need to have a little more time to discuss these things. Dayna, that was amazing.
I would like to echo Dr. Carr for this comment. I think this is one part what we're doing from the medical side of view, but that part is as important as what we are doing, and I would like to add the nutrition, or is it something important for this patient? If we are not going to pay attention to all that things, we're not doing a complete job.
Yeah, and that was great, and I got to go back and make sure our guys are doing this, standing people up. But I think another aspect which you touched upon is when we're talking about a multidisciplinary team, we always struggle with the chaos sometimes we create with the multidisciplinary team, with the families. And it's almost like I've recommended stopping family meetings and having team meetings so that we have a team meeting first and then have a family meeting. And I think that the stress that somebody goes through with all these machines and the family aspects of it, I think is also another great topic that we should create as standards of care for these patients.
You definitely need to have someone lead. Committees are good to get ideas, but if you design something with the committee, it's said the camel is a committee decided by a horse designed by a committee. So we have to be very clear that input should be taken from experts in the field, but then there are people who can translate into something which is meaningful and doesn't look like a camel.
Thank you.
Dayna, thank you very much. Obviously, this brings us to the conclusion.